Good afternoon, everyone. I would like to thank Dr. Talwar for this opportunity. So I'll be talking about what do we look for in a normal OCT macula, what are the features we can see, and what do they mean. So I'll be talking about the basic features, and then Dr. Talwar will talk about which disease will have which features. So OCT, as we know, is possible because of varying levels of reflectivity from the different retinal layers. We do a qualitative analysis and we do a quantitative analysis. In the qualitative, we look at the overall anatomy or morphology of all the retinal layers, any change from the normal, any change in reflectivity patterns, hyper or hyperreflectivity. And then we look at the overall quantitative, that is the thickness and volume of the retinal layers. There are various retinal scans, line scan, radial, raster. But a line scan will give you a lesser information because it will only be in that particular, that meridian that you're getting. So preferable are raster or radial. In raster, you get multiple parallel serial scans in horizontal, and the radial you have focused on the center at the fovea with 360-degree around it. So it's very important that you get the lesion in relation to the fovea, the relation how far it is. So that's very informative. So these are just some. So many lesions you will pick up when you see in raster or radial, which you might miss on the line scan. This is the normal OCT macula where there's a central foveal depression. And we are able to see all the layers very clearly because the interior RNFL layer and the posterior RP layer are very highly reflective. And the other layers in between are of medium or low reflectivity. So each and every layer, you can see here, each and every layer is very easily seen. Sometimes you will see colored pictures, though we are seeing less and less nowadays. More of us are seeing black and white, which give better resolution. But these colors you should know are false colors. So what do they represent? The layers with high reflectivity will appear in the orange or the red section, like the nerve fiber layer, the RP layer, while the layers with medium reflectivity will be in greenish color, like the plexiform layers or the ISOS layer. And the layers with the least reflectivity, they will appear either bluish, blackish, so like the nuclear layers at the choroid, and of course vitreous, which is totally black. So whenever we are evaluating, first of all, look for the quality of the scan, then the position of the scan, and then assess the layers. In the quality, you should be able to see both the inner and outer retinal band. There should not be much of noise or haziness in the image, and then no shadowing effects. So now look here in the first picture, you cannot see inner and outer band in a few areas. Now this is not because of some problem, but you see this thick membrane here, which is causing a shadowing effect, so you're not able to see these. And in the second, you see there's over a lot of haziness, and this can be due to any media opacity, like this was the cataract related in this case. Sometimes you will see some features, but which are not really due to any pathology. So you have to see what they are. Like here, you can see there's a gap here. Here, there's some, wave-like structure. So this is because of some artifacts. So whenever you are in any doubt, always look at the clinical picture. If you feel it is not correlating, then repeat the scan again. So this can be due to eye movements or any blink or any other problem. So coming to the position, always look for the foveal depression. That is very important. Otherwise, you'll always get a false information. If the patient is not able to focus with that eye due to low vision, then you can always try to fixate the other eye with external fixation, or you can manually shift the focus to where you assume the macula to be. Now here you see you're getting an impression of edema, but this is below the macula, so you are getting a false impression. Then coming to the actual assessment. So it's better if you see it in different regions or zones. So we have a pre-retinal area, an epiretinal, intraretinal, and the sub-RP or the subretinal. Now these are the terms that you will usually use to describe the changes in the various layers, any interruption, elevation, thinning, thickening. So this is how you're going to describe them. So coming to the first, the pre-retinal region, this is vitreous, which is not reflective at all, so it's black. But you may sometimes see some kind of reflectivity. Now here you see this membrane, which can be a PVD, or a thick membrane, which can be an epiretinal membrane. Sometimes you may see this kind of a diffuse hyperreflectivity, which can be due to vitreous hemorrhage or any exudate in the vitreous. Second is the epiretinal area. So this is actually interface between vitreous and retina, and normally this is very smooth and regular. So the kind of changes that you can see here, so you can just see that this is this membrane. So this is an epiretinal membrane causing irregularity of the retinal surface. And sometimes this may become so, cause so much of traction that it will distort the whole retinal surface and make it irregular. Some other features that you can see in this epiretinal area, attachment of a membrane, which is called VMA or vitreomacular adhesion, And if this adhesion starts pulling up the retina, then this is VMT or vitreomacular traction. Now here you see there's so much of traction that it has pulled up the whole retina, causing a plateau kind of a TRD. Sometimes abnormal structures present near the fovea may lead to alteration. Now this particular patient actually had a NVE very close to the fovea. So this was showing in the OCT macula like this. Next comes the intraretinal layer. So what are the changes that we see here? Mostly the hypo and hyperreflectivity patterns, then overall thickness of the layers, and then the integrity of the retinal layers. Now coming to hyporeflectivity, whenever you see hyperreflectivity, you will see dark black areas. Usually they will indicate fluid. That is edema. Now you look at the pattern of these. Now here you see this is a diffuse black hyperreflectivity, so this is a diffuse retinal edema. And you also note, see it is respecting the vertical meridian, it's only on one side. So Dr. Tarwal will tell you that which are lesions where you can see this kind of edema. And otherwise you may cystic spaces. There may be small cystic spaces or there may be large cystic spaces, so this is a cystic edema. But not all hyperreflective spaces are fluid. Sometimes you may see these kind of hyperreflective spaces, but they are not due to fluid, they are due to atrophy of the retinal cells or degeneration. So how do you differentiate? It has to be a clinical examination, so good thorough 90-day examination which will help you differentiate any clinical macular edema. Then we look at hyperreflectivity. So here you see these hyperreflective lesions, these are in the outer retinal layer, usually representing a CNVM. So we can look for them, and sometimes these hyperreflective lesions may be very intensely reflective, like these, like in hard exudates, so they will show a shadowing kind of effect. Next, we comment on the thickness and thinning. So any kind of edema will lead to increased thickness of the retinal layers. Any atrophy will lead to thinning of the retinal layers. And finally, we look at the integrity. Are all the layers intact or not? So here you can see in the center, there's a complete loss of retinal layers. So this is a full thickness macular hole. And sometimes you may have a partial loss, not complete. Some layers may still be present. So this is a lamellar macular hole. Finally, coming to the subretinal and the sub-RP region. Now here, hyperreflectivity again is very important, but in correlation to the RP layer. Is the fluid above the RP layer or below? So if it is above the RP layer, then it is subretinal fluid. And if it is below the RP layer, then it is a PED or a pigment epithelial detachment. So it's very important to differentiate because the management of both is very different. Coming to the RP layer, this is a very important layer because many times the status of this is going to tell you what the diagnosis is. So these are, again, I'm emphasizing the terms that you use for defining the changes in this. These are some of the changes that you can see in the RP layer: undulation, elevation, thickening, thinning, so disruption. So this is, you have to look very carefully for these changes. So I'll just give an example. So a case where you can see cystic edema, you can see subretinal fluid. Another case, similarly, you can see cystic edema, but are these both the same? Look at the RP layer here and RP layer here. Now the RP in the second picture you can see is undulated. So which tells that no, these are not the same, they are very different. Another example, you can see subretinal fluid here. Another picture, similar subretinal fluid, but look at the status of RP layer. Here it is straight, but here there is a PED along with undulation. So again telling that these are entirely different pathologies. When we're talking of this area, another term that you should all know is the ellipsoid zone or the ISOS junction. This is very important. So this is where the photoreceptor inner segment, outer segment junction is there. The integrity of this is very important for prognosticating your the visual function. So wherever you can clearly see this, you know the patient is going to recover good vision even if there is edema. But where we have a loss of this ISOS junction, there we know that even if the edema resolves, patient is not going to recover good vision. So it is good to help and inform the patient. One another term, this is drill, that is disorganization of inner retinal layers. So now this time it's the inner retinal layers. Within 1 millimeters of the fovea, if you're not able to distinguish the normal retinal layers, that is the plexiform layer, the nuclear layer, so this is known as drill. And this may occur due to long-standing edema, NDME or BRVO or any other edema edematous condition. So this again leads to poor visual outcome. So finally, coming to quantitative analysis, this is overall mapping the thickness and the volume of the layer. This is very important because serial 3D scans tell us how it's the responding to treatment, whether we need to change our treatment pattern. So monitoring that is important in this. So finally, whenever you're looking at OCT, you should know which disease may show which features. You should go systematically through all the points and always correlate clinically with the clinical pictures and the disease symptoms. Thank you.